Recording. Hi guys, welcome back to your online antenatal education videos. This week we are on episode 4, which is going to be all about the second stage of labour, which is when you're fully dilated and hopefully pushing your baby out. So last week we did all about the first stage of labour up until transition, which is when you're sort of in the established phase of labour and have a bit of rest and digest, just to sort of gather your energy back, have a bit of a moment before your body then is going to go into pushing your baby out. So I just want to think a bit about the transition from the transitional phase into pushing, because this could look different for all women. So your cervix obviously has to be fully dilated, 10 centimeters for your body to be able to push your baby out. This can feel a little frightening at first because you'll feel lots of new feelings that you may not have experienced before, especially if you're a first-time mum. Lots of women often start saying things to us such as, you know, I really want an epidural, I need to go home, call me a taxi, I'm leaving. So that is really, really normal because it is really overwhelming for a lot of people. But that's why, as midwives, we're there by your side, cheering you on, saying this is all normal, just let it happen and try and keep you as calm as possible. Now, when you are moving from transition into the second stage, you will then start having the urges to push. Now, for some women, in fact, you don't get those huge urges to push straight away. Now, that could be for a number of reasons, but we like to try and think about ways in which we can start to encourage your body to start feeling those urges to push. So this is called a passive hour. So if you don't feel that immediate urge to push it fully dilated, we're going to start thinking about, are you energized? Do you need a small snack to have a drink of water or your isotonic sports drink just to give you some sugar? When did you last go for a wee? So we may sort of encourage you to go for a wee. If you're in the pool, you can just go for a wee in there, absolutely fine. Or if you want to walk out to the toilet, then fantastic, you can do that. Because as I'm sure you've gathered by now, us midwives love encouraging you to empty your bladder, as it is very, very important for the descent of your baby's head into your pelvis. We're then going to think about all the positions that are going to help gravity really pull baby's head down onto that pelvic floor to make you and hopefully encourage that urge to come about. So positions we're thinking about are kneeling, standing, squatting, sitting on a birth stool, anything that's going to have gravity pulling baby's head downwards. Because we know that if you're lying on your back flat in a supine position, you're not going to quite get that same urge as if you're upright. Now, when I do my live tour of Labour Ward and Broadlands and maybe the New Forest as well, I will try and show you the birth stool and the pools, just so you get a feel for what they actually look like, and so you can picture yourself on them or in them and what positions you'd like to do whilst using them. Now, other things that us midwives may be thinking about is, what is the position of your baby's head? And Amy's going to talk a bit more about the importance of not only your position, but baby's position as well. And she's going to show you that with the dulum pelvis. But just to know that some women don't always get the overwhelming urge to push. So we'll be there to try and help you to bring that on. But on the other hand, some of you, or most of you, may feel that huge urge to push. Your body's involuntarily pushing your baby down. You'll have really strong, intense contractions, which obviously doing a lot of the hard work as well, pushing baby downwards into the pelvis. And we look at your behavior during this time, and often what it looks like is women making a lot more noise, often making sort of mooey, earthy sounds, which is really good and really normal. And you'll see the midwife getting really excited in the corner of the room when this starts happening. And there's also other external signs that us midwives can look out for as well, sort of changes in your vulva and your vagina, around your bottom as well, to show us that your baby is descending well into your pelvis and hopefully going to be born soon. So I'm going to pass over to Amy now, who's going to talk to you about sort of observations in the second stage and also really good positions as well.
Thank you, Laura. Hello there. So I'm going to talk to you about all the things that midwives will be looking at and monitoring during your second stage of labour before you're going to meet your baby. So you're working really, really hard during this stage. You've worked really hard through your first stage of labour to get to this pushing bit, and now you're going to use all of your last bits of energy to push your baby down and out. So it's really important that we're looking after you and making sure that you are physically coping well with your labour. So we're going to be doing your pulse and your blood pressure hourly. And we're also going to be listening to baby's heart rate every 5 minutes in the second stage. So you'll remember from last week, we were talking about listening to the baby's heart rate every 15 minutes. That's fine in the first stage of labour, but your baby is working as hard as you are during the second stage. So we're making sure that after every single contraction, this baby is still coping well. And still coping well with labour. So the other things that we'll be looking at is, as Laura was saying, the evidence, I suppose, that baby is moving down into the birth canal and trying to come out. So that's looking at how far the baby's head is coming down and the position of the baby's head. Because sometimes, I'm just going to come off of share screen here so that I can show you with the dull and the pelvis. So this is your pelvis. This is the back of your pelvis, your sacrum and your coccyx. And this is the front of your pelvis, the pubic arch. So when the baby is coming down, it's gone into the pelvis. And what has to happen is that the baby has to come uphill. So what it's got to do is come up and around this arch here to be able to come out. Okay? Trying to get the baby out again. So what you will feel is the baby's coming down with every single contraction, and when you're pushing, the baby is coming down a little bit more. Your uterus up here is shortening and keeping the baby down there, and you're pushing and your contractions keep pushing the baby round. So when you are pushing, what you will feel is your baby rocking down. So it's coming down and then slipping back up again when your contraction finishes. You'll then have another contraction and the baby will come down a little bit more, but will slip back again, and that's completely normal. Eventually, once that baby comes round enough and it stays, with the next couple of contractions, your baby will start crowning, which is that stinging, a little bit like a Chinese burn on your vagina. That crowning bit is when the baby's got around that U-bend. But until that point, the baby will still keep rocking backwards and forwards. So during the second stage of labour, it's really important that we keep looking at where that baby is and what that baby's doing. Sometimes the baby's head can be in a slightly different position, and it can stop the baby from coming down as we would expect it to. Now, we can help you with that. We can suggest positions that you can get into to try and change that baby's position. Sometimes they just need a little bit of a helping hand. The other thing that we'll be looking at is the strength and the length of your contractions during this stage. Sometimes what can happen is you've used up all of your energy and you don't feel like you want to eat and drink very much, and you might be just a little bit low on fuel. And your contractions can sometimes slow down a bit during this stage. So it's really important for us to keep an eye on that, encourage you to eat and drink and to be more upright and a bit more mobile possibly. But we'll go on to, when your contractions slow down, the options and what we might be able to suggest to help you a bit later on. So these are some of the positions that we've been talking about. Laura was talking about the birth stool. This is the birth stool here. It's a little bit like it's the shape of a toilet seat. So it helps you into a nice squatting position. And if we think about the dull and the pelvis again and getting that baby round the U-bend uphill, this position is really good for helping your baby around the U-bend. This position isn't quite so good for actually birthing your baby. there is evidence to suggest that using the birth stool when the baby is born can actually increase your chances of having some tearing on the birth stool. So what we would do is encourage you to use the birth stool to get the baby round the U-bend, and then change your position a bit later to actually push your baby out. You can see these positions. The kneeling or the prayer position is really good, and you feel quite in control in this position. Lots of people find it very natural to be in the all fours or kneeling position. Or hanging over the bed here, this is another really good position and good for gravity. Obviously there's a picture of the pool. The pool is a really good place to be in the second stage of labour, because as we mentioned earlier in our earlier videos, you can really get into some really good positions. You can really open up your legs and move your pelvis in a way that you might not be able to if you weren't in the pool. So that's a really good position to be in too. There's a good position here on the ball, hanging on to what we call is a jungle gym that we have at the New Forest Birth Centre. But it could be anything. It could be a rope. It could be, you could be hanging off a door frame or the back of the bed. But lots of women like to be pulling down on something to help them bear down whilst they're in that pushing stage. And there are several other pictures here. This one's quite a good one with the birth partner just sat behind you. That feels really supportive, not only just physically as they're helping you to bear down, but also emotionally, to know that they're there and supporting you is really helpful during that stage. Okay, so progress during the second stage is something that we keep a really close eye on. So for first time parents, if this is your first baby, you're looking at anywhere between 2 and 3 hours from when you're fully dilated and actively pushing to meeting your baby. This varies massively. Of course, women aren't textbooks, so we say it could be 2 to 3 hours. Some first-time mummies come in and push their babies out within the hour. It just is, it's very individual. Labour is very different, birth is very different for every single woman. So we can't guarantee that that's going to be the case. For a second-time baby, a second-time mum, she could possibly be looking at an hour to 2 hours of pushing, but usually it is much more, it happens much more quickly for a second baby than it would do for a first baby. So again, as I said earlier, the positions that we just spoke about would be really helpful for progress. The more upright and mobile you can be, the better. If you're laying down in a supine position, that's really difficult, because again, if I just get the pelvis again and come out of share just so I can show you, because it's important. If you think about this, this is your pelvis standing up, okay? And this is your pelvis laying down. And this bit here is compressed on the bed when you're laying down. And what needs to happen as the baby is coming through the pelvis is that the sacrum and the coccyx, they move to allow the baby to come down. So you can see that if you are laying down and this is compressed, that's really difficult, because not only is the baby going to struggle to come round this bit, but also has to go completely uphill to come up to you, okay? Now I'm going to show you the pelvis in the all fours position, which is like this. You can see this would be you kneeling on all fours or up over the back of the bed. And you can see that as the baby is coming down, the coccyx and the sacrum will be able to move. And what will happen is that the baby doesn't have to go quite so far uphill. It can just come round to you. Okay? Hope that makes a little bit of sense. I'm going to go back to the share screen. Okay. So once you've been pushing, hopefully we'll be able to see the top of your baby's head. And Laura was talking earlier about some of the signs that we would see. So we would see your vagina starting to change shape, and your bottom would start to change shape. And we might be able to see the top of your baby's head. And if that's the case, brilliant. We will stand and watch in awe as you're pushing your baby out, just encouraging you and helping you where we need where you need us to. If after about an hour we haven't started to see the baby's head or started to see even more signs of your baby coming down, then we might discuss doing a vaginal examination just to check the descent of the baby's head, where the baby is, and the position of the baby. And again, that's just so that we can help you to get into positions or change the way that we're doing things, just to encourage that baby to come down. Again, we're gonna be talking about empty bladders again, because it is so important. Your bladder sits where your baby descends. So if your bladder is full, it will just be bouncing up and down on your bladder, and that can really make a big difference on the speed at which your baby will come down. Again, snacks and drinks are really important to keep those contractions strong and regular. And most of the time they will stay strong and regular, but sometimes those contractions do go off a little bit during this stage because you're just running out of energy. Again, we'll do stuff to try and get those contractions moving again, but at some point, if those contractions don't, and the baby doesn't appear to be descending as we would expect it to, we would maybe discuss with you the use of the oxytocin hormone drip. Just to, what we generally say is women can sometimes just have a little tickle of oxytocin that brings those contractions back again, and then you're able to push the baby out. We will talk in a lot more detail about the hormone drip in the coming episodes when we talk about induction and augmentation of labour. But we just thought we'd touch on that just in the second stage, because sometimes that is needed. Okay, so I'm just going to hand over to Heather now to talk about the care of your perineum.
Hello. Yeah, so just briefly, mentioning what Amy just said about getting your hormones going and things, and that we would be talking about induction in a later episode. If you do have a look on the Broadlands page, you will see that the midwives who work in our induction suite have actually put a video on there, because we want you to be assured that coming in to have your labour induced, it is a safe thing to be happening at the moment. So please check out that video as well. I'm going to start off with the first point on here. Where is your perineum? So if we come out of share screen a second, you can see my beautiful drawing. So a little bit of a biology lesson. I am often surprised when women don't know exactly what is what when we're talking about vulvas and vaginas and labia and perineums. So we thought we would just show you a little bit of a diagram, which I sketched very quickly before our video came up. So if you can see this, which you should if it's reflected in my screen, you have got here the view of the vulva. So often the word vagina and vulva is interchangeable, but when we're talking about vulva, we're talking about the external part of your vagina. So this pubic area just here. So at the top, you've got the clitoris just here. Your labia minora, they're the smaller labia that are inside your larger labia, or lips as people call them as well. So you've got the labia majora, labia minora, so big and small. Just here above your vaginal opening is your urethra. So if you ever needed to have your bladder emptied, that's the hole that we would use to insert the catheter tube. So that's where that would go in. Just below that is the vaginal opening. Now, it's really important to us that we get the terminology right, but the vagina is actually the tube that goes up inside, and at the top of the vagina, that's where your cervix is. So this is your vaginal opening just here. So a little bit lower than that, you can see this opening here, which is your anus. And the bit between the vagina here and the anus just there, that is your perineum. So that's the bit that we're talking about there, the muscle and the tissue that is there as well. When we are looking, can I have the slide up again, Amy? Sorry, just to make sure I cover everything. When we're looking at this baby coming down, and as Laura and Amy have said, we're looking at that baby, your vagina is opening, we're seeing babies' cephalus, so the top of their head. We're showing that coming forwards and backwards, forwards and backwards. But there is going to be a stretch on that. So it is really important that you hear the person who's guiding you through this part of labour because although we want you to do big pushes, at some point we are going to want you to pant or do little pushes. When we're practicing pushing, so when I'm talking about it in class, I get women to sort of sit there and push right down into their bottom so that they can really, really feel that push. Some women tense their stomachs, but it needs to be a push right down into your bum. And obviously that the last bit, we want to make sure that that is a slower stretch. So there is a lot of evidence one way and the other, hands on versus hands off. So we're talking, or hands poised. So we're talking about our hands. So our gloved hands protecting your perineum, adding a bit of opposing pressure as this head comes round the bend. We'll talk to you about this as well. Do you want us to do that? Would you rather that we didn't do that? But it does give a little bit of opposing pressure to help as baby's head is pushing behind. We've talked a little bit in classes that I've done before about perineal massage, and it's often a question that we get. Are there benefits to it? Does it prevent tears? Some of the evidence shows, as a recent Cochrane review in 2017 shows, that it can help reduce some of the larger tears, the 3rd and 4th degree tears. But as with many sources of evidence, there's more research needed. So we know that it's not harmful, but we can't guarantee that it will completely protect against having tears. A lot decides on what position that you're in, which position baby's head is in, how quickly they come down. There are lots of different things, but I do know that one of the things we talk about when we talk about hopes and fears in class, people say, I'm afraid of tearing. So that's where we talk about the care of perineum. We know that there are some benefiting factors to water birth because it aids the tissue to be warmer, for it to stretch in the water a little bit slower, and for it to be a bit more controlled. And as Amy was saying, when you're in the water, sometimes it's a bit more palatable to be able to reach down and touch the top of baby's head so that you yourself can feel the effects of your pushing. And when you think, right, this needs to be a little bit slower as well. We can offer you a warm compress. So one of our swabs that's dipped in warm water to press against it, because again, that can make things a little bit more comfortable as well. But what we want is this stage to be quite controlled so that if there are any tears, it's kept to a minimum. The other thing that we talk about is episiotomy. So not everybody knows exactly what it is when we talk about episiotomies, but everybody knows what we say when we say a cut in labour. So time was, certainly when I was at university, my mentors would talk about, gosh, I remember the times when we would do it for everybody, regardless. But it's not done unless it's necessary. So when we talk about instrumental birth in a later video, so when we're using the suction cup, the VOM2s, or using the forceps, it's safer to perform an episiotomy, this cut into the vaginal and the perineal tissue, so that the instruments can be safely applied to the top of baby's head. But there are times when baby's head is coming down and we're looking at the perineum stretched tight, and we think this baby would be able to deflex their head, to stretch their head out if there was a little bit more space. I say to women all the time, if there's time for us to realise that an episiotomy is necessary, there is plenty of time for us to draw up the local anaesthetic so that we are numbing that area as much as possible. It's very effective, it works very quickly, and we infiltrate, so we put the needle into the perineum. We make sure that there's plenty in there. We give it about 10 to 20 seconds, and then when you are having your next contraction and you're pushing, that's when we would perform that cut. Now, when we talk about episiotomies versus tears, yes, they heal a bit quicker, episiotomies, but they're a bit more painful to heal because of where we've gone through the tissue. Tears, a little less painful to heal, but they tend to heal a bit quicker because they follow the line, most part, of the tissues and the stretching in your vagina and on your perineum as well. As you can see on the slide there, it's where we're thinking about babies' distress and, again, to avoid a significant tear. There are different degrees of tears. Some of them need repairs and some of them don't. If they're more significant, there's going to be a higher degree of pain relief that you will need for that repair. So if it's gone into your perineal, your vaginal tissue, it's gone through the muscle, and we can visualize the rectal tissue or the rectal muscles, that's what we call a 3rd degree tear. You'll need to have more pain relief for that, because we want to carefully put those layers back together, so it's done in theatre. It's best to take time over that, because what's important after you've given birth is that you regain control of not only your bladder, but we appreciate that sexual function is a really big deal as well. And we want to make sure that we're doing everything that we can to do those repairs, make sure that everything is back together as it should be. And we also talk about the bowel function. If the effect has gone through the rectal tissue, a 4th degree tear, we want to make sure that your rectal tissue, your rectal muscle, is also effective, so that we are reducing the risk of any bowel and bladder dysfunction. I'll talk about suturing in just a second. Amy, if I can come off share screen a second, I've got my excellent visual aid, which is in fact my hand. Okay, so when I talk about episiotomies, okay, this here is where baby's head would be coming out. So that's the edge of your perineum. Okay, and this is your anus just here. What we would like to avoid is a tear coming directly down here or just here, because that we know can affect the rectal tissue. So an episiotomy is done from the perineum, sorry, from the vaginal opening here, and we come across this way. Okay, so the cut is done that way. And what happens then is that opens like this, opens like that, so that we have got more space. So instead of this, we're now kind of looking at that to give baby's head a little bit more space. And like I said, we would obviously repair that for you. When we look at suturing, when we look at the tears and repairs that we're considering, once you've had a vaginal birth, and baby is up, lovely skin to skin with you, and your placenta has been birthed as well. And we talk about 3rd stage placenta in our next episode. Once that has all been done, we say to you, we need to examine you to see if there are any tears or grazes that potentially need repairing. What we want to make sure is that you're going to reduce the risk of infection, that we are also going to reduce your bleeding, and that you can sit comfortably. So I'm not going to go too in depth into suturing itself, but when we examine you, we tell you exactly what we've found. So if there's a deeper tear, we tell you that it's suitable for suturing. If there is a graze, so if you're looking at your labia like this, just like my exciting diagram back up. So say you have a labial graze here on one side, but not on the other side. Sometimes it's better to leave that if it's not bleeding and it's not going to cause any problems, because when your vulva is closed, when your legs are down and not up and we're not examining you, that will sit together really, really nicely. If there's one on the other side, we want to avoid them healing together. So that's where it might be more suitable to have a stitch. Women often ask, how many stitches do I need? We don't count them. It's done continuously. We don't count the number of them. We want to make sure that the tissue is just pulling together to help it heal. And so that's what we are looking to do. If we have any concerns in either, if you're at home, we can suture at home. We can suture in the birth centres as well. But like I said, if it's a deeper tear or it's slightly more complicated, so it's going off at different angles, we would ask for either a senior midwife to come and examine you, or we would ask for one of our lovely obstetricians to come and examine you as well. Because like I said, we want to make sure that both your sexual and your bladder and bowel function are intact when you're fully healed. People ask that question about, how long do I need to wait for sex after I've given birth? I mean, a newborn baby is quite a good form of contraception, but in terms of when it's suitable for you to give birth, or suitable for you to have sex afterwards, we would say wait for around 1 or 2 weeks if you've had some suturing, because as I said, one of the things we're trying to avoid is the risk of infection as well. So just to recap on that, the positions are really important to keep a note on, so that we're reducing the risk of tears. The examination is important as well. So you might want to have some Entonox, some gas and air whilst we're examining you. And then we will tell you what we found and discuss that plan with you. You can decline suturing if you don't want to have those stitches. It's done with dissolvable tissue, which is a little bit like dental floss. So you might notice a week or so later that when you're wiping after going to the toilet, you see these little strings that are there. You don't need to have them removed. And in your postnatal checks, we also offer you a check of any tears, because we also want to make sure that after we've stitched any tears or any grazes there, we want to make sure that there isn't anything building up behind there, and that the tissue is coming together and healing really well. But the main moral of this story is prevention is better than cure. So everything that we can do to try and prevent those tears, we will do with you, and we will have those conversations with you afterwards, because we keep mentioning it, but there's no decision about you without you. So we want you involved in that decision-making process as well. So that kind of covers it for care of the perineum and the tears and the stitches. As ever, if you have any questions, please put them in the comments below. There's not a foregone conclusion that if you've had a baby before, you would automatically tear again, in the same way that there's not a foregone conclusion that if you haven't torn before and you've had several babies, that you definitely won't tear. There's different factors that impact it. So yeah, that is everything on that.
Thank you, Heather.
Nice.
So I just want to say that during that stage, I know it's very scary to think about sutures and stitches and tearing, but at that point, what I don't want you to forget is that you have your little bundle on your chest, having that skin to skin and that wonderful moment. This is the moment that you're meeting your baby, and you know, all of these things can wait just a little while. You know, you have your baby, and that's a very special time. We'll talk a lot about the golden hour and initiating feeding, whichever way you're feeding. But I just wanted to bring us back to that moment and not leave it with the suturing, because the suturing is the bit that we can worry about. At that point, you will be with your baby, and that's what you need to be thinking about. It's a very exciting time. I have goosebumps.
It is exciting. It is exciting.
So next episode is going to be all about your placenta. So once obviously you've given birth to this little bundle of joy, you then have to give birth to its best friend. So we're going to talk about that in the next episode. So that'll be episode 5. So please tune in for that one. That is going to be next Monday. So watch out for that one. But thank you again, all of you guys that are watching our videos and watching and writing such lovely comments. It's really good to know that, you know, we're informing you guys and making you feel a little bit more reassured about labour and birth and coming in to see us in your desired birth area. So yeah, we'll see you again next week.
Take care.
Bye.
Thank you. Bye.